for the next SSSA training, vein puncture and cannulation, and also contraception and a sexual health update. We will be having training on respiratory courses, and also an introduction for contraception, but the dates will be released in the coming week. We also want to talk to you about the cancer care education. We are currently collecting expressions of interest. We are exploring the launch of Cancer in the Community education program. And the primary goal is to equip nurses, nursing associates, so anybody within the nursing team in general practice, with tools and knowledge to provide best care for patients currently with cancer or after having gone through cancer treatment. So we will also add a link on the chat for you on that. Are there any questions at this stage for us? Anything relevant you would like to discuss? If nothing else, you don't have anything else for us, we will progress with inviting Joanne, who's our guest speaker today, who is joining us to provide training around the winter pressures and management of bronchiolitis in general practice. Joanne, welcome.
Hi, thank you very much, Danielle. Yes, I'm obviously brand new to this group, so I'm not entirely sure what everyone's roles are within the primary healthcare fields, but I'm a clinical education lead for nurses in North Central London, and I've been providing some education to help manage children and young people during winter time. And I was invited, I think, by Maria to come and speak on this topic. So some of it may well be familiar with you, but some of it may not be. So feel free to contribute if you have things to say, because that always makes the discussion rich. But we'll sort of look at basics. We'll look at the NICE guideline for bronchiolitis, and also how we manage children who become sicker and need increasing amounts of medical care. So if I just share presentation. Okay, do you have that? I can't actually see everybody when I've got my.
We can see.
Fantastic, thank you. Do just let me know if anything goes awry. Occasionally there are Wi-Fi issues. Okay, so first thing I just need to mention is, obviously this is an educational resource, a support session. It absolutely doesn't take precedence over any other clinical guidelines or expertise on the clinical front line. So that's just really important to put in context, but hopefully you'll find it useful. And just in terms of evaluating a session, if you could just drop some scores in the chat at the end of the session, or if you have to leave before, that'll be really helpful, because we are quite keen to always evaluate the education in NCL, and obviously welcome any suggestions that come along with that, particularly for improvements and developments. So we're going to have a look at this condition, have a look at these key things: etiology, risk factors, exactly what's going on with the pathophysiology, and some of the ways in which we can help make the diagnosis and provide interventions. So as I say, some of this is likely to be very familiar with you, but hopefully you'll have some new things as well. So in terms of bronchioles and exactly where they are, sometimes it's easy in one's mind to sort of cut off after sort of the main airways and not think hugely about what's beyond that. But of course, the airways become ever smaller towards the end, and more narrow, and eventually end up at the alveolar units. And these are the small airways deep in the lungs. These are the airways that become infected and inflamed in this condition. So how might we simplify that a little bit and also provide some necessary detail? Well, two of the key features of this condition are inflammation of the bronchial wall, as you can see here, and also mucus production. So these things effectively obstruct gas flow through the airways, and therefore it is difficult for the patient to get oxygen into the bottom of their lungs and to exhale CO2. So there's an obstruction with gas flow and with gas exchange, and obviously this can be on a spectrum. It can be fairly mild, it can be much more severe, and occasionally life-threatening. So how might this be defined? Well, one of the systematic reviews that's looking into one of the interventions, mainly the use of saline nebs, it defines bronchiolitis as the most common lower respiratory tract infection in children up to age 2, and occurs when these small structures become infected, causing inflammation, swelling, and mucus production. This makes breathing difficult, especially in very young children who develop coughs and wheezing. So that's what we'd expect. So what are the key causes? Well, RSV, as I'm sure you're probably aware, is the main culprit. And having been on one of the winter pressures meetings this morning, obviously in December there was really quite a high peak of RSV, and local word is that this has now fallen off quite significantly. So there are significantly fewer of these patients presenting in the acute services. So that's good news, and will hopefully help with regulating the patient flow in these areas. But there are, of course, a number of other viruses as well that can cause this. So it's not just RSV. There's other things as well, including coronavirus. Most commonly, obviously, during the winter months and in children under 1 year, with a peak at age 3 to 6. So very few infants are actually over the age of 2 years. And that's really important because it helps us differentiate when a patient may have this versus any other condition. So age is quite a key thing to bear in mind here. So what are some of the risk factors that may increase the risk of an infant or child having severe bronchiolitis? Well, I guess these are expected too, but premature birth is a key factor, especially before 32 weeks, and certainly many of the patients, if not the majority of the patients that we see in the secondary and tertiary services, will have a history of prematurity. Typically, as I mentioned before, under 3 months. Those that due to prematurity have chronic lung disease or bronchopulmonary dysplasia, and also those that have unrepaired congenital heart disease, because that can be hemodynamically significant, especially in something like a ventricular septal defect, where there's altered blood flow and there's effectively far more blood going to the lungs than there should be. That causes other changes in the lungs and puts them at higher risk. There are also patients with neuromuscular disease, and this cohort of patients, I think, is increasing quite significantly. The issue here is that obviously, even under normal circumstances, it's difficult for them to regulate their breathing to cope with any sort of respiratory problem. So if they get a high CO2, for example, where you or I or another patient would just work harder to eliminate that from our bodies, these patients, they don't have the ability to mount that kind of response. So they're particularly vulnerable. And then, of course, patients that for whatever reason have immune deficiency. There are also other more general risk factors, which I'm sure will be, of particular relevance to your own work as well. And this is, there's a lot of sort of more social reasons here, and of course these make sense. If there's infection in a household and there are crowded living conditions, then of course that's much more likely to spread. Parents with conditions such as asthma, atopic dermatitis, these kind of things, presence of tobacco smoke in the living environment, obviously birth during RSV season, all these things are sort of additional things that can help put up the risk to an infant or small child. So this is important to bear in mind. Firstly, because these patients are more at risk, but it's also relevant when we consider what kind of level of care they might need and when. So as we've said, the main problems with this are inflammation of the airways and secretions. There are some other additional things, edema, bronchoconstriction that can come in as well, but these aren't the main the main problems with this condition, but they are present as well. And again, things such as bronchoconstriction, they really do cross over, don't they, with asthma. So you can see how it can be quite difficult sometimes to differentiate these patients. But ultimately, as I said before, the problem here is with reduced gas flow, reduced gas exchange, and therefore increased work of breathing and respiratory distress. So why might this be particularly problematic for children versus an adult, for example, that may get a respiratory infection? Well, this really helps us because we can see here a cross-section of both the adult and the infant airway. In both cases, there's 1 millimetre of edema in the airway. For the adult, that causes some reduction, significant reduction, 44% reduction in airway and cross-section, which is not insignificant. But of course, for the infant or small child with a much smaller airway to start with, this can cause a really huge obstruction and a really significant increase in resistance to gas flow. So that's why these infants are much more vulnerable than older children and adults. So what else is going on here? Well, we can see the things we've already described. We can see here in the cross section of an airway, we've got swelling there, there's mucus production, that all fits with what we've said. However, there are also other things that tend to occur, and one of these things is gas trapping in the alveolar unit. So the patient can breathe in fine, but actually breathing out tends to be a bit more problematic. And this is because inhalation is an active phase. So if there's any problem with it, assuming you don't have a neuromuscular or neurological condition, you can increase your work of breathing to get air inside your body. Air effectively can be dragged into the lungs by the use of accessory muscles. But expiration is a passive phase, and so it's much more likely to be problematic. So air can get in okay, but actually getting it out is more problematic, and that can mean that CO2 is retained in the bloodstream because it cannot be diffused and exhaled. And here we have an example of this. This is the alveolar capillary unit. This is the capillary coming around with carbon dioxide in it. That should just diffuse across that single cell membrane into the alveoli and be exhaled. But this is problematic, okay? And as I said, gas coming in tends to be more okay. It seems to be covered because patients can increase their work of breathing, but this expiration phase can be more problematic. However, in severe cases, there can be a problem with both components of gas exchange, both elimination of CO2 and with oxygenation. So it's important to bear both those things in mind. So we've mentioned some things about symptoms of increased work of breathing. With bronchiolitis, there is also this, often patients have this sort of paroxysmal cough as well, nasal flaring, tracheal tug, wheeze, crepitations on auscultation, and fever, and often preceded by some sort of illness. So that helps us a little bit. But as you can see here, these clinical signs can be common to many respiratory problems. So it's important that we know what they are and think about them and think a little bit about the history there, what might have preceded them. But bear in mind that this is still very difficult sometimes to differentiate. And as mentioned in that previous slide, this can sort of come on a bit of a spectrum. So you can have the patient in the top left who has clearly, got coryza, streaming nose, but is otherwise sort of fairly pink and looking okay, as though they'd be happy to get on with their day. Others can be coughing dramatically, as per the child in the bottom right-hand side there, and others can really be potentially giving up, going quite pale and getting exhausted. So there is quite a spectrum there. Of course, most patients tend to be on the mild to moderate end of it and far fewer on the severe end. And that is definitely true and reflected in the placement of these patients, because they are generally managed in secondary care and only a few have to come to the intensive care units, thankfully. So how might parents or carers begin to manage this at home, because it can really be quite worrying. Well, this is slide shots from the NHS Healthier Together website and the RSV section. And the title of the page is "When Should You Worry?" So obviously the green slide is easy. There are no particular concerns about the infant or child, and so you just keep on monitoring them and bearing in mind the primary healthcare services that are available and the 111 service too. So this seems fairly straightforward and logical and good to know. The amber part is quite different, and it says here, you know, if your child has any of the following symptoms, you need to contact a doctor or nurse today. So I wondered genuinely what your thoughts might be on this, because the symptoms here are, you know, difficulty breathing, fast breathing all of the time, nasal flaring, intercostal recession, not interested in feeding. So that's different to maybe hasn't fed for the last couple. That's really not interested. Excessively drowsy. You know, very high temperature. The instruction here is make contact with somebody. And I wondered what your thoughts might be on that. So I think I think some of these symptoms are quite dramatic, but I know sometimes it's not always considered so. Well, the red part of this code is the part that says, well, okay, you must go to hospital now. And by this point, the child is pale, cold, grunting, cyanosed, seizing, has a rash, has a very high temperature over 48 hours. Well, this is, in my view, sort of, you know, pre-cardiac arrest, as far as I know. And I have to say, I feel as though that's an intensive care admission. This is where they should be coming to hospital. But I know things are different, and I suppose it's just really acknowledging that you know, things can be difficult to interpret, and when children are very sick, it is obviously important that they do access the appropriate services and not feel that they've got to wait until maybe this extreme before they access secondary care. So it's just for further thoughts. If anyone wants to pop anything in the chat or pass on any kind of opinions as to how well they think that this system works and their views on it, then that would be really interesting to know. So from a point of wanting to sort of assess and diagnose these patients and differentiate the bronchiolitic from a patient with anything else, obviously the ABC sort of assessment process is really important. And these sort of basic skills are essential. Pretty good at getting in there, asking questions and using a stethoscope, but actually, you know, observation's also extremely important, and things can be assessed from observation alone. And sometimes, obviously, in winter, infants and children come in with a lot of clothing on, but really, I feel that with experience, this is one of the most important things. You can differentiate those three infants in the photographs I showed before, the severity of and the progression of their illness, and that will tell you something before you then start, you know, feeling them to see whether they're hot, whether there are any secretions on the chest that you can feel, and before you do anything in terms of auscultation. But it all adds in. But ultimately, with these patients, we want to see, okay, are there any signs of respiratory failure? You know, what is their SATS target, and has this been achieved? Now, typically, we're going to be looking at 92% and above, but we do have to bear in mind that we have an increasing cohort of patients with chronic conditions, so maybe chronic lung disease or cardiac disease, and they may have different SATS targets. They may, for example, have SATS target of 85% rather than 95%. So it's important to take these things into consideration and work out, are they within their target range, and have they got an increased oxygen requirement? The respiratory distress we've talked about, but the other thing to bear in mind is just apnea, and that's stopping breathing. And very small infants may present with this symptom alone. They somehow don't go through the compensatory mechanism. They go to being, you know, slightly unwell to actually stopping breathing. Also really important just to check on heart rate, and that's a really good indicator of how seriously someone is working from a respiratory perspective. And then, of course, their neurology, and that photograph that I showed you before of the infant with their eyes closed, this is an example of that. There is a point at which they become exhausted and their conscious level actually starts reducing, and that means that other further impact on their respiratory system. So it's working out how far down the line they are, because there are, of course, these other things that could also be at work. The patient, they could have pneumonia, they could have asthma, some kind of foreign body or tracheal issue. They could also have cardiac failure, and the respiratory signs are actually secondary respiratory signs due to a primary cardiac problem. So how can we exclude these? Well, I mentioned the age of the child initially. That is really important. Clinical symptoms we have discussed, but these are difficult to interpret in and of themselves. But history is obviously really important, and the assessment that we also are able to make in terms of ABC. There are ways of doing RSV detection tests, so that's also useful, and particularly so we don't have to use antibiotics unnecessarily. But of course, in the midst of this, in the midst of so many viral infections, and the importance of treating that for what it is, and not giving antibiotics inappropriately. Of course, last year or the year before, we were suddenly reminded why sometimes antibiotics are given out more readily than we might always agree with, and that's because there are these other conditions in the background. And again, these patients will present when they're in severe state with respiratory distress, but this is not primary respiratory distress. This is a sort of secondary respiratory distress to a primary sort of circulatory problem in the case of sepsis. Obviously, strep A is a primary respiratory one, usually upper airway. And we did have a little cluster of these post sort of lockdown closing and children being bombarded with many infections. So what does the NICE guidelines say? How are they going to advise us to work through it? Well, bronchiolitis, if the infant or child has had sort of 1 to 3 days of illness, they have a persistent cough and either of these things. And in small infants, as I mentioned, they may simply just have apnea and no other clinical signs, no sort of cough, coryza, wheezing, all these kind of things. They may just sort of stop breathing, and that might be a little bit confusing. But this is what the guidelines say. And important to bear in mind that the symptoms usually peak between 3 days. So if someone's presenting at that point, then yes, the illness was likely to be sort of reaching its peak, and they might require more support through that time. But generally, this can be managed and resolved spontaneously. So what are some of the considerations for primary care settings and considerations for referring to a secondary care centre? Well, I touched on these, and of course they are to do with the ability of a carer maybe to undertake care of that child when they're unwell. And was hearing a few more examples of this morning, actually, a slightly different context to do with long-term patients, but there can be reasons why these children require hospital care when others maybe don't. So social circumstances can still be really mixed, as I know you're acutely aware. Carer skill and confidence and an ability to spot a red flag. When have they gone from, you know, green to amber, and when are they exhibiting some of those really serious signs in the red category of the traffic light system? And of course, distance to a facility. So this is all recommended by the NICE guideline as things to consider. So it's important to remember the groups of patients that are more vulnerable than others. Other than those things, the objective reasons, obviously, objective sort of medical reasons, more to do with the clinical signs. We've said apnea, SATs less than 70% in air if an infant is over 6 weeks, and if they're under 6 weeks, target about 92%. Severe respiratory distress, or simply a rate over 70, because again, not all infants may exhibit those signs of increased work of breathing. They may just have a fast breath rate. And of course, if they're not really taking fluids in. So these are also objective reasons for an infant to be admitted. So what interventions might therefore help these patients? Well, unsurprisingly, oxygen can be really useful and is a key intervention. So we would give this in any way that they need it. So obviously start off with low flow nasal cannula, maybe progress to a face mask, but ultimately some of these infants and children may require high flow nasal cannula and CPAP in order to provide some pressure to stop those alveolar units closing down, help keep them open, help keep gas exchange over the alveolar capillary membrane, keep oxygen levels satisfactory, keep CO2 levels satisfactorily low. A much smaller proportion will require admission to intensive care, so a breathing tube, endotracheal tube, and invasive ventilation, and a very tiny percent ECMO, which is effectively heart-lung bypass, and we run that service here at GOSH. It's a very tiny percentage of infants who have failed to respond to those conventional measures. But if they're not responding to oxygen, obviously, as I've said, we just have to bear in mind congenital heart disease always, because this condition of bronchiolitis, it peaks, as I say, within sort of 3 to 6 months, and also cardiac disease can also continue to present in those months too. So it's really just important to bear this in mind with this particular intervention. Hydration, purely just to manage them. I mean, signs of dehydration will be familiar to you, but really important to address those because, again, these infants can get dehydrated and very quickly. Suction of the upper airway sounds appropriate. However, the NICE guideline says, don't necessarily routinely do this because infants fundamentally clear their own airways well. However, if they're having difficulty feeding, then that's going to be important. And certainly, if they've had any kind of apnea, regardless of secretions, definitely do suction the upper airway to check that it's not obstructed. And the reason for not recommending this routinely is because obviously there are associated risks with this. Distress, trauma, consuming oxygen when they're already maybe struggling for oxygen, and also you can get some of these sort of bradycardias because of the vasovagal response. So we generally let them manage themselves in terms of upper airway secretions. But other things such as hypertonic saline may be of benefit to help mobilise and clear secretions. And there may be some evidence to say that this reduces hospital admissions and clinical severity scores. And so this is still used quite a bit. However, I mean, I was relatively unaware that it could also cause some of these problems, but they're mentioned in the Cochrane systematic review of this intervention as things that have been reported. And overall, having looked at this evidence, the NICE guideline is not to use this intervention. Now, I was sort of able to understood why maybe other certain pharmacological interventions may not have been relevant, but I really did think this one probably would be, but apparently not. And it's essentially due to the very low quality of evidence. So I guess that could tell us two things. Either the evidence is low quality because there aren't enough patients to recruit to a study, for example, and definitely there have been some small numbers, or just because it's very, very difficult to study and to get evidence for. So the ultimate conclusion is that, although there was some reduction in severity scores and hospital stay, we cannot recommend it. And I think confidence in the evidence is low to very low, and essentially future studies are need to explore this. So yeah, NICE guideline said not to do it. So bronchodilators, of course, these infants can get a little bit of bronchoconstriction, but it's definitely not the primary pathophysiology. And there are side effects, specifically sort of tachycardia and metabolic acidosis, and they can be quite significant. Now, obviously, if we have a patient with a working diagnosis of asthma, this is entirely appropriate, but for these patients, not. And also, again, with patients presenting with severe respiratory difficulties as an infant and child, we have to consider these other two severe conditions as well. And artificially elevated heart rate in either of these conditions will be particularly problematic because these patients will already have a very high heart rate. What does it say? We found no effect of bronchodilators on oxygen saturation, and given the side effects, little evidence that they are effective, and the expense associated with them, bronchodilators are not helpful in the management of bronchiolitis. So that's what the Cochrane review of this pharmacological measure concludes, and so the NICE guide says, do not use them. However, are they ever justified? And this is where it's all going to be down to clinical judgment. Possibly if infants are over 12 months, because some of those studies, that infants were less than this, or if it's not the first presentation of wheeze, or obviously if bronchiolitis is not the working diagnosis. So this is a really difficult one because it's difficult maybe initially to identify these patients, and especially when they are not in the, getting a little bit older and through their first year of life. So steroids, you might think, yeah, brilliant. Bronchiolitis has an inflammatory component. Surely that might be effective. Well, there are some significant side effects, but actually, the NICE guideline also says not to use these, and that's because they just can't find any evidence that they really do help with the management of this condition. So current evidence does not support a clinically relevant effect of systemic or inhaled glucocorticoids on admissions or length of hospitalisation. Combined dex and epinephrine may reduce hospital admissions, but results are exploratory. The safety data is limited. So we have to say, okay, these are not appropriate either. And so currently the guideline does not recommend them. So epinephrine, is a key drug, obviously, in a cardiac arrest algorithm for boosting, coronary perfusion and cardiac function and return of circulation. But inhaled, this can have a really effective bronchodilation effect. So you might think, okay, that could really help because, again, there's inflammation, there's constriction. But unsurprisingly, some quite serious side effects, quite extreme tachycardia. And also you have to tend to sort of keep giving them. You give them, it might sort of help for a couple of minutes, and then suddenly the effect is lost and there's a rebound effect. And you have to give another one and give another one. It's very, very short half-life, this drug. So there are quite serious side effects to this. And again, the NICE guideline says not to do this, not to use epinephrine as nebulized. There may be some benefit, particularly for the first 24 hours of care, but more research is needed to work out whether or not this really is safe and effective and beneficial. So overall, in terms of these pharmacological inventions, oxygen, hydration, and suction of the upper airway if the patient is apneic, these things are recommended, but these things are not. In fact, the guidelines says do not use these therapies, these pharmacological interventions. And this has sort of changed because the previous guideline, it said a short trial of these may be feasible, may be understandable, may be acceptable, but now it just says don't do these interventions. And I was wondering why this isn't, and one of the reasons definitely is that actually it can actually delay the therapies and the treatments, the interventions that they actually do need. So, for example, if a patient is really struggling to oxygenate themselves, they've had nasal cannula oxygen, they've had, some face mask oxygen, and the oxygen levels are still low, actually giving them saline to try and remove secretions, or steroids to try and reduce that inflammation is much less effective than things such as, starting them on high flow or CPAP. Those are some of the interventions they would need. And actually what you're doing with those, you're helping to deliver oxygen much better. Okay, so that's why those interventions may work, because they support these recommended interventions. So how might care be escalated? Well, again, with everything that's done, there needs to be reassessment And consideration, is there any improvement? Are they better? Are they worse or the same? Sometimes we're definitely desperately looking for improvement and almost start to imagine it, but it's important obviously to at least at the ABC stage, you know, be objective about that. And again, reassess them for signs of respiratory failure. Are they now meeting their oxygen targets, or are they still not meeting that? You know, how does the respiratory status compare now with previously? How does the heart rate and blood pressure compare now with previously? And how are they doing in terms of neurology? Are they still sort of able to engage with a few activities, or, you know, are they very tired and increasingly unresponsive? So this process of reassessment, really important. And the NICE guideline and the CATS guidelines, this is Children's Acute Transport Service that covers North Thames. These are some of the ways that these are the lists that they have to try and differentiate, you know, when a patient is in more in the moderate stage versus a severe stage. And these kind of fit in with those traffic light slides I showed. So use of accessory muscles is quite common, but, you know, severe work of breathing, marked chest recession, grunting, and grunting is a forced exhalation. And as we mentioned, this should be a passive process in the respiratory cycle. Increased work of breathing into inhalation is common. Once there is, you know, force applied to expiration, this is really very significant. Respiratory rate is very high, tiring, reduced conscious level, and even bradypnea, bradycardia, fleeting, and these sometimes fleeting. And I've definitely heard nurses report this to me, say, oh, Jo, you know, actually in hindsight, this patient did have a couple of episodes when they dropped their heart rate, but we just sort of thought it was to do with the suction, or we thought that, I don't know. But of course, you know, it was much more likely to do with the fact that they really were in severe respiratory failure. And so these things are difficult, as you can see, to differentiate. It's difficult in general terms to sometimes figure out whereabouts on the scale you are. And sometimes symptoms are not persistent. They're not consistently that way or consistently the other way. They're not consistently bradycardic or bradypneic or anything like this. So it's difficult. It's very, very difficult. But I think with small infants and children, it's good to err on the side of caution. Well, blood gas testing can help us a little bit with working out exactly how severely unwell an infant is. However, I must say here, the NICE guideline says, you know, definitely don't do this routinely. However, it is acceptable in cases of severe respiratory distress or pending respiratory failure, or if the oxygen is, if you're giving more than 50% oxygen and still not receiving target SATs. And why might this be helpful? Well, gas exchange, as you know, has two components. It's getting oxygen in, it's getting CO2 out. And either one or both of those parts of the respiratory cycle and respiratory system, gas exchange can fail. So in this example, we have a low pH, so an acidosis, and we also have a high CO2 level. So this patient is having problems breathing out and exhaling CO2, maybe because of mucus obstruction to gas flow out of the lungs, or because of gas trapping in the alveolar units. And so in this situation, if we were to have this gas presented, this would be called hypercapnic respiratory failure, so high CO2 respiratory failure. Okay, so the oxygen is actually still okay with this patient. It's just a CO2 clearance issue. Their work of breathing, even though it's increased, it's clearly effective. And the combination of the work of breathing and the supplemental oxygen is enabling them to oxygenate well enough. But there can be situations where they actually struggle with both components. So this is the CO2 component. They've got CO2 retention. They have the hypercapnic respiratory failure component, but they also have decreased oxygen levels. And so this is what we call hypoxemic respiratory failure. So of course, this is much more serious. This patient has both respiratory acidosis because they have a high CO2 and a low pH, plus hypoxemia, low oxygen levels in the blood. So this is how blood gas analysis could help you work out, was this sort of moderate respiratory failure, had a hypercapnic component, or was it severe? And in combination with the clinical symptoms of that patient, this could be really helpful in terms of directing their care. So what might a chest X-ray look like? Well, if there are issues with getting gas into the lungs. If some of the bronchioles have blocked off gas flow, then those alveolar units won't be able to be aerated, and they will become blocked. They will appear more white on chest X-ray. So you typically have a chest X-ray where both lungs are sort of affected equally. Instead of being nice and black as per the X-ray on the left, there can sort of be this white sort of blotchiness, haziness across both lungs. So again, chest X-ray is not routinely recommended in all infants with a working diagnosis of bronchiolitis, but in these patients who are becoming more unwell, it can be really useful because it can help us assess how severely ill they are. And also with chest X-ray, it's not demonstrated here so much, but the cardiac silhouette would show up. So if the patient was to be demonstrating a huge heart, that might lead to another diagnosis. So again, not routine. X-ray changes can be really difficult to interpret, but in severe scenarios where there's ongoing concern and little or no improvement, and where intensive care is being proposed, then this is the right thing to do, obviously. So what might we do with these infants? Well, as I've mentioned, we need to reassess with everything that we're doing, and doing blood gas analysis and chest X-ray. This will help add in to the information that we have. But non-invasive respiratory support such as CPAP will help, because help keep the alveolar units open and help those gases diffuse in and out of the bloodstream and alveoli, help with ventilation, getting gas in and out, and help with perfusion, because when an alveolar unit is open, the blood vessel stays open. What tends to happen is if for any reason the alveolar unit sort of collapses, the blood capillary also collapses and the whole sort of unit fails. So can be really useful for this. Helps gas flow in and out, and helps with gas exchange. So the two therapies we particularly use are a high flow nasal cannula here on the right hand side, where you just have a higher, say 2 litres per kilo of oxygen going through. So for a 3 kilo infant, that'd be 6 litres per minute, versus the 2 litres they might already have by their standard nasal cannula. And the advantage here is that increased high flow, that increased flow of gas through that upper airways overcomes resistance of the upper airways, and it's better delivered into the lungs. So it's better oxygen delivery. CPAP, on the other hand, provides a continuous seal, as we've said, and helps hold the alveoli open directly. Well, interestingly, 2022, there was a trial into high flow nasal cannula and CPAP for liberation from respiratory support in children, and it proved that high flow was not inferior to CPAP, and it's potentially preferable to non-invasive ventilation, other modes. So I've definitely thought to myself, well, I'm not sure how valuable high flow is compared to CPAP, but this trial proves that it has some value. And effectively, what they did was randomise patients. I think it's about 300, 300 to each therapy, 300 to high flow, 300 to CPAP, and there's basically no statistical difference in the time that they were liberated from their respiratory support back into room air. And actually, with the high flow cohort, they had better secondary measures, and that was length of critical care stay and hospital stay. These events were significantly lower with high flow. So I thought this was really interesting. This is a multi-centre UK-wide trial in critical care areas in this country, and yeah, I definitely expected the outcome to be in favour of CPAP. But yeah, this says that high flow is not inferior to CPAP. So that's really interesting. And having spoken to staff in the secondary hospitals, the secondary care settings, they say actually we really do like high flow because we're all confident with using it. We can just go and get the machine, put the appropriate nasal cannula on, and that child receives that advanced level, that increased level of support. Whereas with CPAP, everyone is a little bit more guarded, less sure, much more cautious, and so that infant may not get that intervention as quickly as they would get high flow. So I think there's a lot to be said for this therapy in terms of anecdotal evidence from the clinical front line in A&E and PEDS wards, and also from this trial. So sometimes this doesn't work out, and despite initiating these therapies, gas exchange is still not satisfactory, either or both, either just CO2 retention or both CO2 retention and oxygenation are becoming a problem. And so the patient requires intubation with an endotracheal tube, analgesia, sedation, one-to-one nursing, and an ICU. And the advantage of this is that you can set mandatory breaths, you can set oxygen level, and therefore make a much better job of gas exchange, so that that patient is able to rest and recover. And again, it's important to say here, actually, none of these measures are going to cure the patient. We're not actually giving them anything directly to treat bronchiolitis because, of course, it's a viral thing, that the illness needs to come, it needs to peak, and it needs to pass away. But this is helping support the infant, child, young person through the peak of their illness. So very occasionally in intensive care, even that doesn't work. And this is a very few patients. And so there's another type of ventilation called high frequency oscillatory ventilation. And this has a really high breath rate, 300 plus. Patient has a sort of high level of PEEP applied, and then a very high frequency, so that the patient's chest appears to wobble because the in and out is so very rapid. But one of the advantages here is not only is gas actively put into the lungs, but CO2 is drawn out, expiration is active. So you can see that mechanism might really help somebody who was struggling with CO2 clearance, even with standard intubation and conventional ventilation. Again, very rare, very few patients, but something that is still used, and is used in the intensive care PICU areas. Can also deliver nitric oxide via this machine, and to be fair, via the standard ventilator. And sometimes if it's thought that there's a problem with the perfusion of the lungs as well, the blood vessels are closed down, this can be delivered, and it can help really optimize capillary perfusion. So finally, if none of that works, a very small amount of patients actually require ECMO, extracorporeal membrane oxygenation, and we do see that very tiny percentage of patients, and this is instigated, when basically you cannot oxygenate and you cannot clear CO2 by any of those previous methods. Okay, despite putting them on the highest settings of ventilation, the highest settings of the high frequency ventilators, still their CO2 remains unacceptably high and the pH unacceptably low, and the oxygenation it is not acceptable to sustain life, and likely they have a high lactate level and a really nasty sort of mixed acidosis picture. So essentially the lungs are left to rest. One cannula, carotid vein, takes all the venous blood out into the machine. Gas exchange happens in the machine. CO2 is extracted, oxygen is put in, and the oxygen-rich CO2 cleared blood is delivered back to the patient's carotid artery and aortic arch, and so they receive fresh oxygenated blood that way. Meanwhile, their lungs just rest. Again, this is no direct treatment for bronchiolitis itself. It's just purely facilitating gas exchange while their lungs are down and trying to recover. But of course, this is really high risk. Circuit has to be heparinized. The technical side of it is complicated, so there can be risks, particularly to small infants and brain bleeds. and things like that. So yeah, it's something to be avoided, but it's something that is required in the winter for a very small percentage of infants in NCL. So that's pretty much everything I have to say. Bronchiolitis generally caused by RSV, most predominant in infants less than a year with comorbidities. The NICE guideline is nice and clear. Oxygenation, hydration are really important, and oxygenation via whichever method is necessary to achieve appropriate target SATs, whether that's low flow oxygen, high flow, nasal cannula, CPAP, invasive ventilation, or ECMO. And as with all conditions, just really important to continually reassess them and see where along the spectrum they are, and make a decision. Yeah, definitely on the side of caution, I would say, with these small infants and children. So that's everything I have to say. Feel free to provide any feedback and evaluation scores. Those would be really useful. But otherwise, that's everything from me for this session. If anyone has any questions, I'm happy to try to answer some of them. I'm sure you have much knowledge and experience on this topic yourselves too.
Thank you, Joanne. That was fantastic. Really good to make sure we have insight onto the condition and the management, but also have a bit of an understanding on how these patients are managed in secondary care and the different types of treatments and strategies. I think from our point in primary care, obviously we wouldn't have access to all of those different types of the systems that you have in place.
No,
I
yeah.
mean, not even a CPAP, as far
Yes.
as I'm aware. I wonder whether you have any relevant content or flyers that we can share with parents when we review these patients in general practice. You've shared some things around red flags, for example, on there, and I think it would be key when we're doing that assessment to also have a sense of what are the parents' abilities to detect those red flags and whether we actually need to escalate it much quicker.
Yeah, I mean, I could definitely ask. I don't have anything additional sort of for primary care. I mean, I think those slides are what I've retrieved from the Healthier website, the Healthier Together website, which is where patients, I think, and families should be referred to. But I do think it's just really difficult to interpret those, and I do think they're quite complicated. And I do think my own view, this is my own view, is that you know, with small infants and children, we should err on the side of caution. And if someone's having difficulty breathing, I frankly think they have a right to see a doctor there and then. And if the GP can't see them or whatever reason, then they need to be seen in A&E, I would say. I mean, I've been to A&E, you know, with a sore knee because my knee swelled up. You know, if that's legitimate, which it totally was, then it's got to be legitimate for an infant with any form of difficulty breathing to go to A&E. And I think sometimes these guidelines can be taken to heart by the most diligent parents, and they are concerned not to come to A&E or any secondary care services because they might be presenting. But really, I think it's much better for patients to present earlier and not sort of just pre-cardiac arrest, as I feel that I mean, obviously, if you have got those red flag signs and they need to be actioned, but you know, I think any doubts or any concern, they should be seen by someone on the day at the time. And I don't know what other people's feelings are. I mean, you've probably seen a lot more patients than I have at this end.
Yep, I fully agree with you on that. We should have a low threshold when managing children in particular. Thank you very much for joining us today. If nobody has any questions, can you please make sure you add the evaluation on the chat? Joanne, can you please just show us again, how did you want it?
Oh yeah, just out of 3 for I've got it just out of 3 for sort of theoretical background, clinical application, and overall presentation. So 3 out of, I'll just get the slide up again. Hold on. Yeah, so that would be just like
Thank
that.
you. So if you can please score from 1 to 3, you can either do it on the chat now, or if you want to contact us directly, we'll be happy to support and feed that information to Joanne.
Yeah, that's absolutely fine. It can be added into the chat any point, even after the session's finished. So that's not a problem.
Okay, so we have 4 minutes left. Happy to release you to before you go back to your clinics. Thank you all for joining.
Thank you.
Lovely. Thank you.
Thank you.
Thank you.